We are live.
Good evening, everyone. Welcome to the iFocus online lecture 452 of the refractive surgery module. Today, we will be discussing all the points to keep in mind while selecting patients for refractive surgery. For the session today, I would like to introduce our moderator, sir, Dr. Garvit Bhutani, sir. He's a senior clinical fellow in East Lancashire NHS Trust, United Kingdom. Sir has done his MBBS from Government Medical College, Surat, India. Sir has also finished his MS in ophthalmology from PGIMR, Chandigarh, India. Sir has completed fellowship in cornea and anterior segment from LVPI, Hyderabad. Sir also has DNB, FICO, MRCS UK, and FRCO of the UK. Previously, Sir has worked at Center for Sight, DDU Hospital, Delhi. Sir has presented multiple papers, posters, and presentations at various national and international conferences. And he also, Sir has been a member of several ophthalmic organizations in both India and Europe. Welcome, Sir. I would
Thank you.
like to hand over the introduction to Sir.
Thank you. Thanks for the kind introduction. And many thanks to the organizers for having me over there. First of all, I would like to welcome our chairperson today, Dr. Shalini Sharma. Dr. Sharma is a senior consultant cataract and refractive surgery at iCare Hospital in Noida. She's done her MS in ophthalmology from NSCB Medical College in Jabalpur. Previously, she has worked in St. Stephen's Hospital and Shroff Hospital in Delhi. She has a extensive experience in training refractive surgeons in Vadodara, and she's been actively involved in teaching and training of various national and international trainees at iCare. She has been integral part of Alcon FACO development program at iCare, and she's actively involved in organizing multiple workshops for practitioners for skill enhancement. Welcome, ma'am. Welcome to the
Thank you
iFocus.
so much. I'm honored to be part of your iFocus. Thank you so much.
Okay, so coming to the star of the show today, Dr. Lakshey Dudeja. He's currently running his Dudeja Iron ENT Care Center in Sonipat. Previously, he's worked with Center for Sight, and he's done his MBBS from the prestigious Maulana Azad Medical College, MBBS from KMC Mangalore. Following that, he moved to Arvind Eye Hospital for a fellowship and then did a fellowship in cornea and microsurgery in Arvind Hospital, Madurai. He's also done his ICO fellowship from Michigan Kellogg Eye Center. He previously worked for, I guess, about 5 years, sir, for Center.
Yes.
Yeah. So welcome, sir.
Thank you.
We are not waiting for you to start your extremely knowledgeable and important session about A to Z of patient selection for refractive surgery.
Thank you so much. Can I share my slides, Garvita?
Yes, please.
Visible? Slides are visible?
Yes, sir.
So thank you for having me. Welcome Shalini ma'am and welcome Garvit. Please guide me through this session. I'll be trying to make it as easy as possible for the listeners, and you'll be helping me out to solve any doubts or if I miss anything. A to Z of patient selection for refractive surgery. This is the topic for today. So the purpose of preoperative assessment is to determine if patient is fit for refractive surgery, to determine if patient needs a cornea-based or a lens-based refractive procedure, and to identify which is the best procedure for the patient. So most important step is proper history taking. In history taking comes age of the patient. So we need to know that their refraction has stabilized, the age is well above 18, occupation, why he wants the refractive surgery, use of glasses or contact lens. And here I would stress that contact lens should be off before doing any corneal topography pentagram. So for soft contact lens, it's generally 2 weeks, and for RGPs, it's generally 1 month per decade of use of RGP lenses. Stability of refraction. So at least 1 year of stability of refraction is needed. Psychological profile of the patient. What are the expectations of the patient? And what brings him to your OPD for refractive procedure? What is the nature of his job? What is the motivation behind this refractive procedure? Sometimes they have inappropriate expectations that this will eliminate reading glasses, this will improve their best corrected visual acuity in amblyopia, this will correct their dry eyes, headache, improve their night driving, improve their night vision. And we need to stress, if it is job related, that 6/6 is not guaranteed. There are chances of regression, there are chances of multiple complications. We can try for 6/6, but there is never a guarantee of 6/6. So this should be made clear. Ocular history. So ocular history, if there is any history of ocular inflammatory diseases or herpetic ocular diseases, history of Sjogren syndrome, these patients, they might be using lubricants which may mask the symptoms. So history is very important. Any kind of endothelial dystrophy, because this makes flap adhesion difficult after LASIK procedures. Other points in ocular history are glaucoma, because during LASIK treatment, IOP may rise well above 65. So this may cause damage to optic disc. Blepharitis, all signs of blepharitis must be absent prior to treatment, as this may induce post-operative inflammation. Nystagmus, because all lasers do not have trackers and these involuntary movements can cause difficulty. History of squint surgery. So these were demographic history, ocular history. Now we ask about systemic history. So autoimmune diseases like any rheumatoid arthritis, SLE, thyroid disease, immune suppression, HIV or immune suppression, pregnancy or lactation, we should wait at least 6 months after cessation of breastfeeding, because this may cause change in refraction. Any hormone therapy, history of keloids, history of epilepsy, patient should be at least, last seizure episode should be at least 12 months before we consider for treatment, because he needs to lie down stably for the procedure. Another point in history is drug history. History of acne, history of sumatriptan, which causes risk of vascular occlusion when IOP rises during surgery. History of any medications for OCD or personality disorders, because this changes or alters their expectations from the surgery. So if any patient is on any psychotic medications, that history is very important. Professional history, history of any contact sports or with history of any kind of profession which has physical contact or physical injury. So wrapping up all the history things, there should be a well-motivated patient having very realistic expectations with age above 18 years, and power should be stable for at least 1 year. After history, next is examination. We need to assess uncorrected distance visual acuity, best corrected visual acuity, near vision, and binocular vision status. So in binocular vision status, we should note if a patient has any diplopia, which is corrected or controlled by prisms. If so, this needs to be considered, or squint pediatric ophthalmologist opinion has to be taken before planning LASIK. Manifest refraction, cycloplegic refraction. So normally we use tropicamide refraction. Homatropin refraction is done if the patient is a hyperope. Lensometry of spectacles. This will tell us for about the stability of power, and change of 0.5 diopter over 1 year is also considered significant. Other points in examination are tonometry, near point of convergence. If convergence is weak, patient may need convergence exercises before surgery. Usually myopes, they have low convergence, and when we correct myopia after LASIK, sometimes patients have difficulty in reading. So convergence exercises before surgery is very important for those who have convergence insufficiency. Color vision, this is basically important for those who want LASIK for job related reasons. So after vision assessment, next examination is external eye examination. So lid posture, where the patient has any ptosis, position of eye with and without glasses, cover test to rule out any phobias, ocular motility, orbital anatomy to assess if patient has deep set eyes or a narrow palpebral fissure. Slit lamp examination, we should assess tear film height, lid margins to see for meibomian gland dysfunction, conjunctiva to rule out papillae, cornea, we should assess if there is any scar, anterior chamber depth if we are going for a lens-based refractive procedure, lens to rule out early cataract, and fundus examination, dilated fundus examination to assess disc macula and myopic peripheral retinal degenerative changes. If we see any degenerative changes, patient needs referral for retina evaluation, and if there are certain holes, he needs to be barraged before LASIK. Other point in clinical examination is dry eye workup. We need to see for tear breakup time, which is checked by putting fluorescent dye and checking for first point of breakage, tear film breakage, which usually is if more than 15 seconds, it's normal. Next is ocular surface staining, Schirmer test. Normally Schirmer 1 is enough. If there is a dryness seen, then we can do Schirmer's 2. Otherwise, Schirmer's 1 is enough. More than 10 mm is considered normal. Meibography, pupillometry. If pupil is more than 5 mm, chances of glare and halos are more. So we have covered history and examination. Next part is investigations. So most important investigation is corneal topography, pentacam. In this, we see these two things. These are most important: 4-quad map and Bellin-Ambrosio enhanced ectasia display. In 4-quad map, on sagittal map, if K reading is more than 48, this is a suspect cornea. If skewing is more than 22 degrees, if superior inferior difference on 5 mm circle is more than 2.5 diopter, with superior being more than inferior. And if inferior is more than superior, a difference of 1.5 diopter is considered significant. Difference between KM between two eyes if it is more than 2 diopters. On elevation maps, any isolated island or tongue-like extension, these values you should memorize, which is 8 and 18. On anterior elevation map, if any point is elevated more than 8 microns, and on posterior, if it is 18 micron for myopic patients, these are suspicious. On thickness map, superior inferior difference at 5 mm circle if it is more than 30 microns, thinnest location if it is less than 470 microns, thickness at the apex minus thickness at thinnest location if the difference is more than 10 microns. Y coordinate of the thinnest location, which is seen in pentacam. So if thinnest point is displaced downwards, if y coordinate is minus more than 0.5 mm or 500 microns, this is suspicious. Difference in thickness between the two eyes at thinnest location more than 30 microns is suspicious. Next is Bellin-Embraccio enhanced ectasia display. So by combining elevation and pachymetric data, BAD produces a display that is more sensitive at picking up early changes by comparing the data to an enhanced best fit sphere. To make it easy, the first image shows a best fit sphere, right, which has taken consideration the steepness of the whole cornea. So this is the average best fit sphere, the yellow one on the top. So if we see the ectatic cornea is only slightly above it, which may be missed. But if we take a best fit sphere, the red one below, best fit sphere, which excludes the cone, so that becomes little flatter, which excludes the cone, then the cone becomes more pronounced. So this is Bellin-Embraccio display in which we exclude central 3.5 mm. So the central part is excluded. So instead of best fit sphere, we used a enhanced best fit sphere. This pronounces or makes it easier to detect any elevation. So these are the bad displays. If you see, first row shows the baseline elevation maps. So these are the baseline elevation maps with the best fit sphere. The second row shows exclusion maps in which the best fit sphere, instead of best fit sphere, the machine uses a enhanced best fit sphere and excludes central 3.5 mm. So the points of elevation become more pronounced. And the third row shows the difference between the two maps, right? Then there are certain other parameters, D values, D front, D back, D pachymetry, D thickness, D ART. So these D values also denote certain things like D front shows D value related to front elevation, D value related to back elevation, D value related to pachymetry changes, D value related to thinnest point, and one overall D value. Then there is cornea thickness spatial profile, which shows how the corneal thickness changes and how percentage thickness increases from central to peripheral cornea. So if the slope of these falls out of these normative data and if it is steeper, then they are suspicious. So this shows that if anterior elevation, if it is more than 5 and posterior if it is more than 12, these are suspicious. And D values, if it is more than 2, they are suspicious. Other investigations are corneal biomechanics, for which we use ocular response analyzer or Corvis ST, which is nowadays used. So Corvis ST gives us two main things, which are CBI and TBI. CBI is Corvis Biomechanical Index, which gives gives index about the biomechanical properties of the cornea. So what it does is it throws an air puff on the cornea and sees or judges how it deforms. So it gives an index for that. And the beauty of this is it can combine data with the tomographic data also. Pentacam D values or bad values also. So if CBI is also analyzed along with tomographic data, it becomes TBI, which is tomographic biomechanical index. So if these two are also deranged, this also is suspicious cornea. Some people check contrast sensitivity, and wavefront analysis also checked using aberrometry. The relevance, I will come to it later. So we have for now judged history, examination, investigation of the patient, and then we know broadly whether this patient is fit for a refractive procedure or not fit. Now we are assessing what is the best procedure for the patient. Before we judge the procedure, we need to know what are the procedures available. So we have cornea-based procedures, lens-based procedures, and bioptics. Cornea-based, PRK, LASIK, SMILE or SILK, lens-based, phakic IOL, or refractive lens exchange, or combination of both, which is bioptics. So in laser-based procedure, it can be only excimer laser-based, like PRK or microkeratome-assisted LASIK, or femtolaser and excimer laser-based, which is femtolasic, or only femtolaser, SMILE or SILK. These are the FDA-approved range for procedures. For LASIK or PRK, it is up to -10, and for SMILE, it is only minus and not yet plus. Cylindrical, less than 4 for LASIK and PRK, and less than 3 for SMILE. Phakic IOL can be up to -20, and customized can be even more. So we have an ideal candidate who's more than 18 years, stable refraction for 1 year, no contraindications, adequately counseled, and has realistic expectations. Now we judge certain parameters for the patient. Few parameters are residual stromal bed thickness. So what is residual stromal bed thickness? It is calculated by preoperatively calculating central corneal thickness and then subtracting flap thickness and ablation depth. So we have a corneal thickness, we will subtract the flap thickness and the ablation depth, how much we will ablate for correcting certain refractive error. So this RSBT should be more than 280 microns. For calculating ablation depth, roughly it is 10 to 50 microns per 1 diopter of refractive error. And there is one formula, refractive error multiplied by optical zone square divided by 3. One more parameter is percentage of tissue altered. So percentage of tissue altered is flap thickness plus ablation depth divided by total corneal thickness. So this is the tissue we are altering. We are changing flap thickness, ablation depth divided by total corneal thickness. If it is more than 40%, this is suspicious. We should not do it. It should never be more than 40%. Combining all these is one ectasia score, which takes into consideration topography, RSBT, age, corneal thickness, and refractive error. More than 4 is high risk. Keratometry. So post LASIK keratometry after myopia correction will be approximately preoperative K minus, because we are making the cornea flatter, 80% of the refractive error we are correcting. So this is the rough estimate. And for hyperopia, it will be pre-op K plus 100% of the refractive error, and post-operative K should be roughly between 34 to 48. This is to avoid higher order aberrations. If we go less than 34, make it very flat or make it very steep, this increases chances of higher order aberrations. So according to these parameters, if RSBT is more than 280, residual stromal bed thickness is more than 280 microns, percentage tissue altered is less than 40, and post-operative K is between 34 to 48, we go for a cornea-based procedure. If it is not this way, then we may think for think about lens-based procedure. Amongst cornea-based procedure, there are three types: PRK, LASIK, and SMILE. So PRK, surface ablation, is done for thin corneas. If there is a low refractive error, patient is predisposed to trauma, or he has chances of recurrent corneal erosions. For low, moderate, and high, SMILE and LASIK can be done. SMILE is preferred for patients who have mild dry eyes because we make a smaller cut in SMILE, so corneal nerves are damaged less. So for mild dry eyes, SMILE is preferred, and for contact sports. For aberrometry is done to assess higher order aberrations. If patient has more higher order aberrations, more than 0.3 microns, then wavefront guided or topo guided LASIK are considered. If higher order aberrations are less, then wavefront optimized LASIK is considered. These are the criteria for phakic Patients should have adequate anterior chamber depth more than 2.8 microns and should not have any lenticular opacities. So for lens-based procedure, if patient is more than 40 years and has early cataract changes, refractive lens exchange is preferred. If age is less than 40 and the lens is clear, then phakic IOL is preferred. So this slide summarizes how to select which procedure for which patient. So if RSBT, residual stromal bed, is more than 280, percentage tissue altered is less than 40, and post-op KM is 34 to 48, we go for a cornea-based procedure. If cornea is thin, low refractive error, patient is predisposed to trauma or recurrent erosions, PRK can be done. If cornea has adequate thickness, LASIK can be done. And if patient has mild dry eyes, then SMILE can be considered. But if the RSBT is less, tissue altered is more, and post-op KM falls less than 34 or more than 48, then lens-based procedures are considered. And if age is less than 40 with clear lens, phakic IOL can be done. If age is more than 40 and there are early cataract changes, then refractive lens exchange can be considered. Bioptics can be done for very high refractive errors when we combine both the procedures, but with customized phakic IOLs, this procedure is rarely done. Thank you very much. I request Shalini ma'am to share her thoughts.
Yeah, Dr. Lakshey, it was very comprehensive presentation. And I think you have covered every aspect of selection of refractive cases. One more thing I would like to say that sometimes we need to be the realistic approach to the whole refractive procedure is very important, especially
Yes.
in the cases where the age limit is just the borderline, something somewhere around 40. When the patients are in that age group, the realistic approach we should adapt for the patients, because then these kind of the patients are, are the patients which are not happy by the refractive procedure which we have chosen.
Yes.
And sometimes the enhancements are required in these cases where, near patient is around 40, near glasses are there after the surgery. And so we have to be very realistic when we are planning. uh, Dr. Garvit, would you like to add on to something?
Ma'am, it was a very comprehensive lecture. I was actually taking notes throughout the lecture.
Yeah, even I was writing
I
some
think
practical points.
yes, very practical points, especially about the unrealistic expectations. I mean, we all have had patients who are about 40 or nearing 40 when they realize, especially people who are in jobs, they've got the money now, they were from a humble background, they couldn't afford it before, and they come to your clinic and sit there that, see, yes, I want this refractive surgery. I've heard about LASIK or SMILE. I think uh, in those cases, the approach becomes a bit difficult, I would say, because you have to tell them that, see, either you'll get glasses back in terms of reading, or you'll have to probably give them an option of compromise in terms of distance vision, leave them a bit myopic, gives them a bit of an intermediate reading. So I think there comes the importance of what job they do and what are their uh, expectations. I remember having one patient who was about 45-year-old, wanted a refractive surgery, um, had an early start of cataract. I mean, with proper counseling, he eventually underwent for a cataract extraction, interestingly, at that age, and went for a multifocal or a trifocal lens. I don't remember now, but he was happy afterwards because the expectations were cleared beforehand that he may have a little bit of, glare and difficulties in night driving. He came back for a post-op follow-up and he was okay. Yes. Having said that, I don't advocate doing this for every patient, but carefully selecting patients who want what kind of refractive surgery, uh, involving the patients probably in the decision making about what refractive surgery they would like to go for. Um, I don't know, I mean, what's your experience about these patients who are like borderline age 40, 45, who come for refractive surgery opinions?
So, I suggest, like, depending upon the need of the patient, like if the patient is actually, there are patients who are, they just want to, at this age also, they are okay with the near glasses, but they actually don't want to wear the distance glasses. So for them, I think we should go ahead. There should be no hitch in, planning the refractive procedure for these kind of patients, because they will be very happy if they even get off from their glasses. So my approach is that if the patient they are just looking for a distance correction, I go ahead with the LASIK procedure. And if even for the ICLs also, very recently I've operated one female who was not getting was had some issues with her job, and she was 42 years old and very high myope. But she was very, very keen for any kind of refractive surgery, because she was a single parent and really keen for, she was not getting the job. So I offered her ICL, and she was really, the outcome was very nice and very happy patient. So we should not, looking at the age, we should not refuse the refractive procedure straightforward, because still if, in that 40 to 45, we can still, there will be patients who are really happy getting the distance glasses off. One more thing, Dr. Lakshay, I keep my residual stromal bed to 300.
Yes, ma'am.
I always keep it 300. 280, I am not comfortable. I feel that
Yes, ma'am.
that thing we should. And for the correction of myopes, anything more than 7.57, even with the CCT is very high, say even it is 580, 590, and I know the enough residual bed is there. I don't offer anything more than 8 diopters for LASIK correction. Then I will shift myself to ICL. That is
Okay.
my practical approach in my practice. So I little guarded in that, I believe. What is your approach, and how,
And we
Dr.?
also keep above 300, but textbook said 280,
Yeah,
so I had
yeah,
written 280.
yeah. And for the correction, how much you all can?
Less than 10 only, ma'am.
Less than 10. Okay.
Yes, ma'am.
How about you, Dr. Garvit? You go beyond 8 for LASIK?
No, ma'am, I'm not very comfortable going beyond 8 for LASIK.
Hmm.
I've had experience with PRKs in that range, which work
Hmm.
fine in my hand, at least, I would say. But LASIK, I would avoid 7 like you said. Yeah, I would agree with you on that.
Right. So,
Do we have any questions from any of
Garvita,
Yes,
any?
sir.
Uh-huh.
Sir, I have one question. Like, for example, most of the patients who do come to for refractive surgery, most of them are under a treatment from dermatologists and all for isotret or minoxidil and all these topical therapies. So, in your practice, how long do you wait before posting such patients for refractive correction, sir?
I think there should not be any active inflammation in the eye. And if you assess there is no dryness without lubricants, then you can proceed. If patient is already using lubricants, then you checking dryness, the symptoms will be all masked. If there is no dryness without lubricants and there is no active inflammation, no active dryness, you can proceed. What say, Garvit?
Similar thing, sir. If the patient's not having any active inflammation, then you can proceed. There is
Yes.
active, we stop. Yeah.
Okay. Yes. Thank you.
So,
But sir,
question.
sorry, I just one more thing. Like, what I have observed, like isotret can also lead to a change in refraction. So, how do you approach that? Like, how do you know that refraction is good? Because I am very skeptical of always approaching patients under topical therapies of isotret, oral or topical minoxidil and all.
Yeah, I have no such experience of change in refraction because of these. Garvit, have you noticed?
No, sir, not in my knowledge that refraction changes much. But yeah, I think I would say the key word which Shalini ma'am used was keen to get the surgery done. So sometimes it comes down to taking those decisions when the patient's sitting with you in the chamber and how important it is for the patient to have the surgery done. And these might, I would say it's a minor thing. It doesn't cause a major change in refractive error. So major things, as Lakshay said, has covered about stability of refraction, correct age, and meeting the right expectations. Those are the most important things when you are selecting your patient for refractive surgery. But if you are skeptical, there is no harm in telling the patient that yes, we can wait, but if patient has some urgent reason to undergo and patient understands the risks of possibility of a small refractive error change, you can go ahead. There is no guideline as such to say that you're not allowed to do it.
Right. Thank you, sir.
Ma'am, what's your take on this?
Yes, as you said, and as Dr. Lakshya said, it is very subjective. I have not come in my practice across someone who is actually, having any changes in refraction being on these drugs. But then we have to assess what is the need of the patient at the moment, because there will be young girls, young patients who are getting married and they have acne, and we just can't outright reject these patients for not doing surgery because they already, these are the most of the time, these are the females. But if still you are very cautious about your procedures, you can just repeat it, ask the patient to stop the drug for, say, for a month or so, and then repeat your refractive thing and your pentacam, repeat again, or even the 3 scans. I always prefer getting 3 scans done repeatedly with a gap of 2 weeks and see how the change is there after stopping the drug, or anything in my mind for that matter, not only the drug. And if there is repeatedly, there is no change in the pentacam and in the dilated refraction, is one thing which is very important. We should be very, very, even when we are apart from these drugs, any patient who is coming for any refractive procedure, we should be assessing the refractive, dilated refraction very closely in these patients. If there is no change in the dilated refraction, and even if there is a slight subjective change, manifest refraction, still I would like to go ahead because the dilated refraction is very important for me.
True, ma'am.
Anything else?
Garvit, any other point?
Yeah, Kanika.
Important point covered was external examination and doses. I would share an experience of a patient who came back and said, "Oh, my eyes look a bit cross-eyed, or there is some droop in the eyelid." One thing that I started doing after that in my practice was I would tell all my patients, before you have the refractive surgery done, please take a photograph without glasses and keep it as a record for yourself. That gives you also a bit of a protection and gives them also an understanding how they look like without glasses. They might be wearing glasses for 20 odd years since adulthood, and they don't know how they look like without glasses because some of them have never even used a contact lens who come to us.
That's true, sir.
That's true.
I
Yeah.
think Pavitra, this is one of the best advice that I received recently to get the patient picture clicked before the surgery. Really very good option there. What I was trying to ask previously from all the panelists is, let's say if we have a scenario where we have a young diabetic. There are two conditions to it. A young diabetic recently diagnosed, not a very long and good sugar control, or a young diabetic who has been diagnosed before but has a very good control. What are your thoughts on whether you want to triage this patient out for the refractive surgery procedure, or you wait, sir and ma'am, or whether you proceed in the current scenario?
Yeah. So, Kanika, the sugar control is very important. If the sugar is well controlled and there is no retinopathy, and patient is in like he's not close to 40, number of years of diabetes, these are the certain things I look in a diabetic patient. If the patient is diabetic more than 10 years, close to 40, HbA1c is not very great, probably I would refuse the patient. Someone in 30s, good diabetic control, HbA1c is very good, no retinopathy, like 6 months or a year being diabetic, I will like to go ahead with a good sugar control. How about you, Dr. Lakshay and Dr. Garvit? What is your...
Diabetics, yes, you are right, ma'am. I think diabetics, they should understand that there is a possibility of change of refraction based on diabetes control. So this needs to be put in their head that there is a chance even after refractive correction, if your diabetes control is not good, your vision may get blurred, you may not have a good vision. So diabetes control before surgery is also needed, and even after surgery is also needed if you want to have a persistent effect of that refractive procedure. So if all these things somebody understands and there is no retinopathy as you mentioned, we can consider.
Garvit, sir, your thoughts on the same?
See, diabetes is a relative contraindication for having a refractive surgery. So when the word relative comes into play, it becomes a discretion of kind of the surgeon and the patient to decide what's best for the patient's interest. So you speak to the patient again, how keen, what the patient wants. Obviously, the diabetes control, HbA1c, how long the patient's been diabetic, what are the odds of this patient getting a diabetic retinopathy in future, which will fail your surgery basically. So how all these things matter when you're discussing with the patient. The other thing that patients do need to realize is uh, diabetics are known to get early cataracts, and so everything needs to be discussed probably with the patient to for the patient to understand that yes, these are the things that you need to be aware of. And if you're happy to proceed, we can do the surgeries. Doing the surgeries the easiest thing, I would say. But having that proper conversation with the patient is the most important aspect in a refractive surgery, I always feel. Once you have had that conversation, patient's happy to proceed, then go ahead, unless there is something which is glaringly contraindicating you to go ahead with the surgery.
Scenario three, sir. Let's say this patient who came to you at the first go, and we said, okay, the diabetic control is not good and you have more chances of landing up with the retinopathy or cataract in future. Let's say this patient becomes very serious, gets his diabetes under control. What would be your cutoff value? And once it is well controlled according to your cutoff values, would you then proceed with surgery for the same person who has well controlled diabetes after initiation?
Yeah.
Tough situation.
Yeah.
Be the cutoff value for the HbA1c, sir and ma'am, in your practice that you would prefer as a good control?
As such, HbA1c, like a good control, something less than 6 should be a good thing. And uh, IDDM is one diabetes which I generally avoid. Like if the young patients with IDDM is not a, these are the patients which I'm not very happy, until unless there is something which is really apart from cosmetic, there is something therapeutic patient is looking for in the refractive procedure. I would not like to go for that patient.
Lakshya sir, your thoughts on the
Yes, true. I mentioned one thing also, that pre-op refraction sugar stability is one thing, and post-operative is also needed. Plus, as ma'am mentioned, how keen he is to get it done after listening all these negatives. If still he wants to go for it, it's okay. But I have never come across, after me negatively counseling so much, somebody still going for it. So I would like to discourage, telling him that refraction may change, you may get retinopathy, you may get early cataract, you will get reading glasses after 40. So after listening all these things, I don't think somebody would agree for that.
So, sir, by chance, I really landed up with one such patient.
Okay.
Surgery, in spite of all the counseling and negative counseling, he was like, okay, I'm ready to take the risk. Even if I get my number back, that's fine. I want to go ahead with the procedure. It took me a solid amount of time to convince him against. And then he said, okay, fine, I'll come back with a good control. He's not yet landed in my clinic, but yes, I did come across one patient, and that prompted me to ask this question to the panelists.
We are
Thank
waiting the
Okay.
day when he
thank
lands in your clinic.
I suppose he must be now window shopping and going to other places. Someone must be ready to operate on him.
I think few doubts have also popped here. Why is glaucoma evaluation important in patients about to undergo refractive surgery? So two, 3 points are there. Number one is, we are changing the corneal thickness, right? So we are changing the corneal thickness in the refractive procedure. So post-operative IOP measurement would be slightly different. Second thing is, intraoperatively, the pressure rises more than 65 mm. So if patient has any glaucoma, it can worsen. So these are the 2 points. If you want to add something, Garvit.
No, I think you've very well covered everything, probably in the lecture as well, about glaucoma. The pressure goes really high, especially in the
Femtolasic.
procedures involving suction, list,
Yes.
smile, um, and the pigment release increases if you do a lens-based procedure, ICL. So these are the procedures I will be a bit reluctant to do in a patient who has got probably a suspicious disc or high pressures noted in the past. But the other things that go on with it is somebody might be a steroid responder, and you need to give steroids, especially if you're choosing PRK after the surgery. The steroids go on for long, and if it's a steroid responder, then you're landing up in trouble again to manage those things. So I would probably add a gonio assessment in patients who are undergoing LASIK before, to make sure the angles are fine and there's not much of pigment release, because a lot of myopes, um, they are predisposed to having glaucoma in future, and they need to know that yes, this can happen, and these are the particular types of risks I would essentially discuss with them before consenting them for the surgery.
Okay. Ma'am, anything to add, ma'am?
Family history of glaucoma,
Okay.
again, to be overemphasized in, especially when we are taking patients for ICL.
Yes, ma'am.
ICL and any past history of, as Dr. Garvit said, and you said very correctly, any past history of steroid response, any
Yes, ma'am.
previous, and pigment dispersion, as we all know, is high in these kind of patients, myopes, and gonio assessment is again very important aspect when we are planning, especially ICLs to,
Yes, ma'am.
sizing and all. So that is
Yes,
important.
ma'am. Next is, and aberrometry is required pre-op workup in every candidate. If not, then which situation requires the aberrometry profile to be done? I think it should be done in all. We should assess higher order aberrations in all. If it is more, then we can do guided LASIK, wavefront guided or topo guided? Garvit, any thoughts? I think we should do it for all.
Yeah, we do it
Maybe,
for all. We are
yes.
doing it for all. Yeah.
But the situations where it's not available for all, which patients would you like to choose? Any thoughts on that?
I think most LASIK places they have aberrometers.
Yeah.
If it is a smaller center, they may not have LASIK also. Yes. Garvita, any other thing?
Sir, I think these were all the questions that were posted by our DNB students, and I don't see any. I see some questions on YouTube that I can ask, sir. One is, do you step up treatment for rheumatology before refractive procedures?
No, we don't do. We assess the dry eye. If patient has dry eye, then treat dry eye, get a rheumatology opinion. If patient has dry eyes, if patient dryness is well controlled, why to step up, then not to step up.
Right, sir. One more question, sir. How? Sorry. Sorry, ma'am. Please continue.
Please continue, Garvita. Please continue.
Okay. I just wanted to ask another question that was posted on YouTube, which was, how does hormonal therapy affect refractive surgery?
Hormonal therapy, because of hormonal therapy, you taking hormonal therapy or pregnancy or lactation, which causes hormonal changes, this can change refraction. This can alter refraction of a patient. So that is why the patient should not be on hormonal therapy because it causes change in refraction, causing mild corneal edema or swelling, which can change the corneal power. Garvit, anything else?
I agree with you, sir. Absolutely correctly said. Hormone therapy is basically same as pregnancy or lactation causing refractive changes.
Yes. Garvita, any other?
That's
Or
all,
we
sir.
should?
Well,
Okay.
sir.
Okay, then let's formally end the session.
Thank you, sir. Thank you for your
Thank you.
comprehensive,
Thank you,
detailed.
Lakshey, Dr. Lakshey. Thank you, Dr. Garvit.
Thank
It
Thank
was
you.
very nice. Very nice, actually.
you,
Lots
ma'am.
of learning, lots of discussion. Great.
Thank you, ma'am. Thank you, Garvit. Thank you, Garvita. Thank you,
Thank
Kanika.
you, sir.
Thank you, everyone. Good night.
Thank you,
Good
sir.
night. Thank
Thank
you,
you, sir.
everyone.